SSI, SSI, SSI is one of a kind organization of scientists with human mind. SSI, SSI, SSI.
Early onset scoliosis, definition, etiology, and classification. And these are my disclosures. The definition of early onset scoliosis is not so easy to come up with. It's a very heterogeneous group of diagnoses and pathologies. And since growth is such a factor in promoting the progression of spinal deformity, I've chosen the term the presence of a structural scoliosis or kyphosis in a child with no secondary sexual characteristics constitutes early onset scoliosis. There is a multitude of other descriptive diagnoses that are out there. If we look at just infantile idiopathic scoliosis, we have historically classified this as infantile up to age 3, juvenile 4 to 9, and adolescents over that. It may be more appropriate to divide that into early onset up to age 5 and late onset 5 and older, as this is the period of accelerated growth below 5, where the onset of the deformity has a high likelihood of cardiopulmonary compromise if left alone. Growth is such an issue in spinal deformity, and we'll look a little bit more at that. And growth really is a change in proportions of the relationship between the trunk height and the subischial leg length. If we look at birth, the trunk is about twice as long as the legs and progressing to near equality by maturity. So there's a very significant gain in both, but more significant in the lower extremities. And we see the change in proportions in your upper left. This demonstrates the T1 to S1 growth in boys, and from birth to maturity we have a change of 25 centimeters, with the majority coming between birth and 5, and then in the adolescence 10 to 15. So if you can get the early onset child to the age of 5 or 6 without an operative procedure, the likelihood of getting that child to over 10 is relatively high. And we can see that a vertebral arthrodesis between T1 and S1 at age 5 results in a sitting height deficit of 15 centimeters and corresponding diminished pulmonary function. Conversely, the spinal canal is nearly mature at age 5 with very little growth beyond that. Thus, decreasing spinal canal size is really not a factor in surgery after the age of 5. And finally, the fourth dimension of growth is growth of the thorax. And this is very significant. We'll see the newborn has only 6% of the adult thorax, 50% at age 10, and not 100% until age 15. So we can diminish thoracic growth by premature arthrodesis of the thoracic spine. Pulmonary development has a similar pattern with alveolar development, progressive, reaching adult size at age 8. The airways are developed before birth, and the pulmonary vasculature develops to the size of the lung and thorax, not according to age. So why is EOS a problem? Two things: short trunk and bad cosmetics, and early surgery against poor pulmonary function. These two landmark studies with long-term follow-up of early fusion surgery shows uniform decreased pulmonary function and decreased thoracic height. So the etiology it can be simplistically divided into idiopathic, either infantile or juvenile, congenital, syndromic, neuromuscular, or others. And we can look at that a little bit closer. This is from the Growing Spine Study Group database, which shows the relative distribution of the categories of early onset, with neuromuscular being the most common, and idiopathic, syndromic, congenital, and others. When presented with an early onset child, this crosses multiple pediatric subspecialties, and all should be involved, particularly medicine, genetics, pulmonary, neurologic, orthopedics, and others as needed. Imaging is mandatory of these, and certainly plain digital x-rays are the baseline. The neural axis MRI should be obtained in most instances, particularly in the non-syndromic and non-neuromuscular child, to rule out intracanal pathology. CT scans should be reserved for surgical situations due to radiation. And this is the slide we saw earlier on idiopathic, and we'll look at infantile in particular. Infantile comprises less than 1% of all idiopathics. It's a male predominant, left-sided curve, with a very high rate of spontaneous resolution. The genetics are really unknown. And I'm sure you're all familiar with the meta angle of the rib vertebral angle difference. The method of measuring is shown here. And when there's no overlap of the rib head with the vertebral body, there's low incidence of progression. When there's overlap, there's high incidence of progression. In general, the RV-AD is useful. It's less than 20, it's likely to resolve. If the Cobb angle is less than 25 and the RV-AD is less than 20, there's low risk. And if it's greater than 20 degrees in phase 2 and the Cobb angle greater than 25 to 30 degrees, progression is very likely. Treatment is not my charge, but this is the usual with the progressive, going from early diagnosis, attempted delaying it with CAS, voice, and usually eventually the progressive curve such as seen here. The second category we'll look at is neuromuscular, and neuromuscular comprises approximately 30% of all early onset cases, and the distribution from the Growing Spine Study Group is seen here with myelodysplasia, cerebral palsy, and spinal muscular atrophy, and arthrogryposis, the leading offenders. These present early on. Usually the more severe the neuromuscular condition, the more severe and more highly progressive the scoliosis is going to be. If you look at the neuromuscular versus the idiopathic patients, there are many differences that we're all aware of, and that's in life expectancy, the ability to participate in activities of daily living, the pulmonary capacity, the comorbidities, the nutrition and the muscular coverage around the chest, immunity, bone density, growth pace, and growth retardation. These are all factors to consider in the neuromuscular patient. And Dr. Yassizi of Turkey talks about the low risk versus the high risk in neuromuscular patients, and what leads him to consider what type of surgery he's going to do. In the low risk with good skin, good cardiovascular system, satisfactory pulmonary, a device that requires multiple lengthenings may be employed. And another low risk of good skin and good pulmonary, a lengthening type device. And the corollary is the high risk, the poor pulmonary, the cardiovascular system is bad, frequent respiratory infections. You may consider a growth-friendly type device such as a Schillerth. The next category is syndromic disease, and this accounts for about 21% of early onset. with neurofibromatosis far and away the most common offender. Chromosome abnormalities and Marfan syndrome are likewise common with early onset of scoliosis requiring early intervention. And this is an example of a neurofibromatosis child who failed conservative therapy such as repeated castings, bracing, without intracanal pathology, who underwent a spine-to-spine growing system. Congenital early onset accounts for approximately 20%, and this may be defects of segmentation, formation, or mixed failures. Finally, a short look at treatment goals, and this would be correction of the deformity, primarily prevent progression, minimize pulmonary problems, normalize spinal growth, facilitate care, and improve the quality of life. I'd like to, since classification is my charge, I'm going to take the last couple of minutes and talk about treatment classifications. This is a quote from Dr. Sponseller: significant practice variation exists among surgeons for the method of treatment, but there's some consensus on indications for surgery, including curve size, diagnosis, age, and final fusion. And probably there's less consensus than this would imply. And the treatment options are shown being non-operative, buying time, or fusion surgery, either posterior, anterior, or dissection. And finally, the classification of growth-friendly procedures. And this is a classification of growth-friendly procedures by the chest, wall, and spine deformity study groups. And we may have distraction-based, which is shown to be growing rods, the vector, or the magnetic type devices. This may be guided growth, such as the Lukey trolley or the Shoah. And finally, compression-based, such as tether or staple. So we can not only classify the types of EOS, but classify the growth-friendly spinal implants. We'll skip over this. And this is just an example of the vector, the growing rods, distraction, which I'm sure you're going to hear much about. Staples and a tether by Dr. Mikey. So when to use what? It's somewhat age-based. The distraction-based is our workhorse with the spine-to-spine or spine-to-ribs. Is the younger child, the guided growth, the Shelley or the Lukey trolley is probably less surgery and less growth, preferably in the age group of 6 to 9. And finally, the compression-based, the tether staple. In general, it's one surgery, we hope so, over the age of 8 to avoid overcorrection. So in summary, early onset deformity comes in a variety of shapes and sizes, with a variety of etiologies and a variety of natural histories. We can define and classify, and this may be of some help in determination of treatment.
Thank you very much indeed, and I thank the organizers for inviting me to speak today. These are my disclosures. So, as Dr. Schaffelberger has indicated, treating the immature spine is a challenge, and early onset scoliosis is a particular challenge. The aims are to stop the progression of the curve and to allow the maximal growth of the spine, lungs, and thoracic cage to continue. Now, there's no universal solution that exists that effectively addresses curve correction, spinal growth, pulmonary and function and maturation. And young children develop severe deformities due to the rapid progression of the deformity. Many of these patients have coexisting syndromes and the associated medical conditions only make things harder. There are 4 main categories: the idiopathic, the congenital, the neuromuscular, and syndromic. And it's very important to understand that you may not realize that the deformity, what we call an idiopathic, may in fact, at its outset, actually be part of a generalized syndrome. And I think it's important to actually actively look for congenital, for comorbidities, including congenital heart disease and other system involvement. And it's also important in every single one of these cases to assess their pulmonary function. So the key aim is to distinguish between progressive curves from spontaneously resolving ones, which includes both the infantile and juvenile types, a systemic examination to detect plagiocephaly, guinal hernia, hip dysplasia, foot and ankle deformities. And certainly it's important to do an MRI scan in these patients because a large percentage of them have have intraspinal abnormalities, including Chiari and split cord malformations, as well as tethered cords and syrinx. The importance of this being that these may need to be addressed before we address the spinal deformity itself. So what are the differences from traditional AIS? Well, how does the EOS idiopathics differ from AIS? Well, firstly, they are more kyphotic. The apex is more distal, as well as the stable abneutral vertebrae. The curves tend to be of a larger magnitude and become very stiffer and have poorer abilities to compensate. The Biglio charts, as you know, spinal growth, there are two stages of maximum growth from birth to 5 years and 10 to 15 years, and then a reduced, but nevertheless, growth velocity between 5 to 10 years. If untreated, these patients do have both cardiopulmonary compromise and the subsequent sequelae. Conservative treatment, observation, casting and bracing. My colleague, I think it'd be reasonable to briefly pause here. In Mehta, my colleague at the Royal National Orthopaedic Hospital in Stanmore, was of course born in Calcutta and a great supporter of Mother Teresa. She spent a lot of time with her and did a lot of work here in Calcutta. So she still is around, and I'm still in touch with her. And she described the rib vertebral angle difference as being a discriminator in the more progressive curves. And she showed in her paper published in the Journal of Bone and Joint Surgery excellent results in a selective group of patients. Her philosophy was that the RVAD together with the phase was an important discriminator, but she did not hesitate to treat the more progressive curves with her technique. And if you have an area of rapid growth, if you guide it with a cast, very much a Ponseti type of approach would assist in an initially curved spine to gradually straighten out. And her inclusion criteria: increasing cob angle, RVAD of greater than 20 degrees, phase 2 rib transition, and double curves for the ones that she treated. This is very much an art as well as a science. It took her about 2 hours to get this cast on, and it's actually what drove me to surgery as opposed to treating these conservatively. But nevertheless, she had a very good technique, a very patient technique, and she insisted that this was corrected not only by traction but also by derotation and lateral pressures. And the completed cast looks something like this. It allowed room for not only the opposite side to expand out, but also for the abdomen as well. So, if treated early enough, certainly between the ages of 2 and 4, it has an incredible rate of success in the infantile group. But it also, in the other patients, buys time because there are limited treatment options. The cast, as I said, works better if started as early as possible, even sometimes in the first year of life. And the program should be stopped once failed, and this is very important, particularly when other options are possible. The pitfalls of definitive spinal fusion, again, has been discussed extensively. Short trunk, disproportion of the upper trunk and the lower part of the body. The crankshaft phenomenon, particularly if anterior surgery is not performed, and the cardiopulmonary compromise and thoracic insufficiency syndromes in these very young children. Laurie Carroll's paper, which was referred to earlier, early definitive fusion in these patients restrict lung function, and you get restrictive lung disease, and also have progressive deformity in up to 40% of patients, and it's not something that is now recommended. Surgery, you have to medically optimize these patients prior to surgery. It's very important to have a pediatrician involved, have the pulmonary and airway management, nutritional support in many of these patients, understand that some of these patients are osteopenic and that you're going to have difficulties with fixation and anchorage. But the important point that it is something that is multidisciplinary and requires very much a teamwork approach. So what do experts do? Really, there is very little consensus. The rib and spine-based distraction systems are equally popular. Again, what is agreed is that early definitive spinal fusion should be discouraged. Again, in terms of the available techniques, you can have a single rod, a dual rod, nowadays the magnetic driven rod, staples, the Vepta, which is available, and the Schiller procedure. So, in terms of current treatment, 66% of the patients who came to modern surgical or available surgery had casting facilities. 77% had access to halo gravity traction. Only 27% used it in practice. 39% used Vepta, and 93% would all agreed would treat a 2-year-old with a 52-degree curve non-operatively. Again, 12 common cases presented to 13 experts, wide variation in treatment preferences. The consensus for use of Vepta and fusion to pelvis was 70% at best. So the outcomes, again, very little known until now, none available until March of 2011. There is, of course, the EOS questionnaire, 33 items in 13 domains. There is an enormous emphasis on pulmonary function in recent times, quite rightly. It's a key factor for the long-term successful outcomes. The current strategies are directed towards improving not just the core backbone, but also FVC. Professor Campbell will no doubt in his large talk, which you will have available tomorrow, cover some of the issues regarding pulmonary function in great detail. Greg Redding, who was his pulmonologist for many, many years, has written a great deal about this, and I think it's very interesting to hear what they have to say. So, we also know that a reduction in core angle does not necessarily correlate with an increase in the FVC. And I am just going to tell you my own personal experience. Firstly, we looked at the MRI studies in 31 patients with early onset scoliosis. 26% of them had neuroanatomical anomalies, the most common being a Chiari-1 malformation. And again, I've used growing rods in the treatment of these patients, either single or dual, inserted submuscularly or subfascially. My own preference is a submuscular insertion, and I have used in the past both single and dual constructs. And the technique that I used was a domino cross connector fixed to each rod at 2 consecutive points. And I independently distracted each rod against the fixation, each of the fixation points. And I used to post-operatively brace only until the foundations were solid. And this is a typical case. Actually, this is one of the first cases that I did in 1996. And Samir Dalvi was my fellow at the time, and he assisted in this case. And this case eventually graduated to a spinal fusion. And we published our series about the use of that single rod technique in spine. Now, the dual rods, Berouz published a large series in 23 patients and found that there were low incidence of rod fracture and dislodgement. However, the wound issues were greater than in the single rod, and there was, however, an improvement in thoracic cage volume. We looked at the amount of forces that was needed for distraction during each distraction, and we showed that the distractive forces doubled by the fifth lengthening, and we actually quantified the amount of forces and actually demonstrated in this study the law of diminishing returns. Oops, I think we've lost it here. I need to get back to this. So also I want to present some recent advances and my experience with the magnetic growth rod. In this situation, you have an external remote control distraction to avoid repeated GA and hospital admissions. Again, we published our early results in the Journal of Bone and Joint Surgery. And we have also in these patients, particularly in the neuromuscular patients, showed an improvement in the pulmonary function, and we presented this at the last SRS meeting. We started the development of a non-invasive growth rod in our facility, and subsequently MAGIC developed this into a system, and it does provide a distraction of the spine in EOS. The safety and efficacy was tested successfully in the human model, and then the lengthenings are performed by the surgeon in the office in the outpatient department. This is what it looks like, and again, the nice thing is that the patients don't have to come into surgery at regular basis and get the open surgery, and this can be done very painlessly and in about a minute in the outpatient department. So we published our large series, our first series in the Journal of Bone and Joint Surgery, and it is now my preference for most of patients with early onset scoliosis who failed casting and bracing. And again, the technique involves a submuscular bed, 2 incisions, insertion of anchors at the top and the bottom, just as we did for the conventional growth rod. And then the rods are contoured and inserted. And we showed in our series that we keep up with growth. The distraction is done within a few minutes in the outpatient department. This is an example of a patient with a single rod who had a 32 millimeter lengthening at the 2-year period. That patient has now subsequently had a fusion 3 years following the onset, or 3.5 years following the onset of the first treatment. This is another juvenile patient whose treatment is still ongoing. We've developed an algorithm for it. So essentially, growth-guided surgery is an accepted standard of care in this patient. We do not, on the whole, perform definitive spinal surgery. It's important to appreciate the difference between this early onset idiopathic and AIS. The magnetic growth rods have promising early results. Thank you.
Pleasure to be here. Third trip to India. This is my task to cover this topic. Here are my disclosures. You certainly know the definition of congenital sclerosis being sclerosis due to an anomalous formation of the spine in utero. We know that it's separated into defects of segmentation. We see here block vertebral unilateral bars. And defects of formation, with the most common being various forms of hemivertebra. Segmentation of hemivertebra refers to the amount of disc space and thus growth potential above and below the hemivertebra. A fully segmented segment has disc above and below, or partially segmentation is disc only found above or below. And non-segmented incarcerated means no disc above or below, and obviously those have the most favorable natural history. Recently, Noriaki Kawakami from Japan has further classified congenital scoliosis based on the use of 3D CT scans in these 4 types. Type 1, solitary simple congenital deformity is this L1 hemivertebra. While type 3 complex is this severely kind of jumbled spine, as I call it, early onset deformity, producing a severe kyphoscoliosis. We know that congenital deformities are associated conditions such as renal anomalies and cardiac anomalies that we need to be aware of, and various syndromes such as Bader syndrome that we often see. As was mentioned earlier, all these early onset patients, especially those with congenital deformities, deserve an MRI scan prior to any surgical treatment, certainly and often at the time of initial diagnosis. And we find probably somewhere between 20 to 30% incidence of spinal canal abnormalities in these deformities. A recent study looking at a very large series of congenital hemivertebra found that 28% of isolated and 21% of complex hemivertebra patients had intraspinal anomalies detected on MRI evaluation. A thorough exam of the patient is performed. Obvious skin lesions, as seen here, need to be noted, which obviously correlate with a higher incidence of intraspinal anomalies. Extremities need to be evaluated. A complete and thorough upper and lower extremity neurologic exam. Neck alignment and motion must be evaluated, as well as checking for hip dysplasia. Various MRI abnormalities can be seen, and this actually is seen in one patient who I'll show later, who has basically every potential neuroanatomic abnormality possible. So the carrying malformation, syringomyelia, diastematomyelia, tethered cord, all seen again in this one early onset congenital scoliosis patient. Natural history of patients with EOS congenital deformity really depends on the type of deformity, the amount of growth remaining, and we do know that these can produce severe curves with cardiorespiratory compromise. We know one of the most unfavorable prognosis is having a unilateral bar, seen here on the concavity, and a contralateral hemivertebra on the convexity. This often produces very malignant progression with growth. We also can see, even despite our best attempts at controlling these deformities, that we can have malignant progression. As you see here, a very mild deformity beginning treated with a vector device, leading to a very severe deformity where basically the spine is, we lose control of the spine here in the coronal plane. Observation as treatment can be performed for smaller curves, more skeletally mature patients who have balanced deformities, or they have deformities, congenital deformities with minimal progression features, as in this incarcerated non-segmented hemivertebra, where a 5-year period there's really no progression. Bracing has a limited role. Usually we will not brace the congenital component, but we may consider bracing an idiopathic component below, as seen here, where we try and control the left thoracic idiopathic deformity despite treatment of the proximal thoracic congenital deformity. Indications for surgery include scoliosis deformity greater than 30 to 50 degrees, that's progressive, if it's unbalanced. Rarely, there may be neurologic issues involved that warrant operative consideration. It's really very dependent on the pathology that we see. I'll go through these 5 types of surgery that can be performed. 5 basic groups of and categories of surgeries. The first being fusion in situ, which I emphasize to be careful with because often, especially in the early onset patient, can lead to progressive deformity. There's potentially a good reason to do a in situ fusion, a cervical thoracic unilateral bar or fused ribs at an in situ fusion. And 12 years post-op has fairly good control of this proximal thoracic curve with some progression of a idiopathic curve below. However, this patient is a little different. This patient at age 3 had a circumferential short fusion in situ for congenital kyphoscoliosis, and 8 years later, this patient has severe malignant progression of the deformity. So uninstrumented fusion in situ, especially in the mid-thoracic region, can have malignant progression despite a solid fusion. Here's a model of the spine made, again showing the severe angular deformity. The tented, thin spinal cord at the apex producing myelopathy, requiring a fairly major resection procedure with early onset of motor paraplegia with full recovery by 1 year post-op. So a very dangerous problem and very dangerous procedure, again, from a fairly innocuous initial problem. Probably the best treatment for congenital deformities are those hemivertebrae that can be excised with a very short fusion. Here's an example of a 1 plus 10-year-old boy with a L3 hemivertebra that's non-incarcerated and fully segmented, so a high risk of progression, already producing a 52-degree deformity before age 2. So approximately 14 years ago, we performed an anterior and posterior hemivertebral excision with a short kind of crook closure mechanism here, which very nicely controlled the congenital deformity up to 10 years post-operatively, as you see here, with excellent photos, clinical photos at 10 years post-op. However, this is a reminder we must always continue to follow these patients. 3 years following this, and 13 years post-op, he had malignant progression of an idiopathic curve in the thoracic spine and ultimately required surgical fusion. So we always must follow these patients all the way through skeletally maturity. Common treatment of fully segmented hemivertebra includes all posterior hemivertebral excision and pedicle screw fixation as seen here with the 6-year follow-up. This is an excellent way of treating these patients through a single posterior approach. After exposure and hemivertebral identification, which is very important because sometimes the hemilamina does not correspond to the hemivertebral body. We have to make sure that we know exactly the segment that we're going to excise, so we identify this both clinically and radiographically. Hemivertebral pedicle is surrounded and the nerve roots protected, while the hemivertebral body and disc is removed down deep to the spine. We correct the deformity by convex compression as the first maneuver on the convexity, and then we distract a bit on the concavity again to create full correction of the deformity over a single segment fusion. Jürgen Harms and Michael Roof have one of the better publications on single-level hemivertebral excision in congenital deformity treated posteriorly, showing very nice correction, especially in those patients without bars, and a little less correction in the patient with bars, but still very excellent treatment for these congenital deformities. Next is a BCR type procedure with a shorter fusion. And this can be performed for this kind of patient, a 6-year-old with a severe progressive kyphoscoliotic deformity with a kind of jumbled apex here with normal vertebra above and below. This is progressive and the patient's having very early myelopathy from this, so this is something that needs treatment. So here we'd like to do a 2-level resection, decompress the cord, and doing as short a fusion as possible within the limits of this deformity. One could argue that we could have added a growing construct higher and lower on this patient, but I'm bracing them and trying to maintain growth that way instead of with instrumentation because of the stiffening effect that we see whenever we put implants across the spine or chest wall and or chest wall. Another good reason to do a resection procedure is congenital deformities that produce imbalance. Here's a young patient with a congenital deformity at the apex with progressive truncal imbalance to the left. So an apical asymmetric resection is performed and the trunk is rebalanced here 2 years post-operative with this resection and short apical fusion. Next, very commonly we make growing rods or vector constructs, the type of growing constructs into patients with congenital early onset deformities. Here's a patient with a combined treatment of a resection of a hemivertebra producing a proximal thoracic deformity that's controlled well with a short fusion above, and then treatment of the idiopathic curve below with growing rods. So this is a combined treatment that we occasionally use for these type of patients. For patients that have more severe deformities, we prefer preliminary halogravity traction. Here's a patient that I showed before that has severe multiple neuroanatomic abnormalities with this progressive kyphoscoliosis here. That in halogravity traction slowly and safely stretch out the spinal column and spinal cord prior to application of growing rods. So here's the clinical view before and during the traction. And you see the skin incisions for all the neurosurgical work that had to be done prior to our intervention with growing rods here. And in these kind of patients with kyphoscoliosis, I actually do compression on the convexity to correct the kyphosis after, and then secondarily do distraction on the concavity to correct the scoliosis. So we do 2 stages of different growing rod realignments on these kind of severe kyphoscoliotics. I mentioned halo gravity traction. We use a lot of this in early onset patients, including those with congenital deformities. We just reviewed 45 patients in the early onset period, having either growing rods, shows, or vectors placed. And we find better ultimate kyphosis correction if we do preliminary traction than if we don't. Standard protocol includes not only just sitting all day in traction, but walking in traction, eating and working in traction, getting pulmonary therapy in traction, so it's a very active traction with nutritional pulmonary optimization as well as stretching the spine and spinal cord. Now there's some patients that really need the traction. Here's a congenital lordoscoliosis patient with an iliac axillary deformity with also spinal canal anomalies and a tethered cord. This patient's stuck. But with 6 months of halo gravity traction, we slowly and safely stretch out the trunk prior to application of a complex growth rod procedure. Suffice it to say, there's no way I could safely produce this in without the traction performed preliminarily, and it would have been much neurologically risky as well. Same thing, the sagittal plane, severe lordoscoliosis form with the trunk sitting way forward pelvis was nicely corrected with the traction and secondary growth rod application. Now, there's been some nice reports showing the safety and efficacy of growing rods for pediatric congenital deformities. And basically, they're found to be a safe and effective treatment technique in selected patients with congenital deformities, as we've seen. I won't spend much time, obviously, but many patients with these type of contracted hypoplastic hemathoraces from congenital deformities with rib fusions obviously compromise the space available for the lung, and due to Bob Campbell's great work, showing us how to do open wedge thoracoplasties, thoracotomies on the spine, and then applying these vector devices to maximize chest wall alignment in these constricted hemathoraces has made a great benefit to many of our patients with these type of problems. There are problems though with any kind of growth device. Obviously there's anchor pull-off we must worry about. Not getting appropriate perches above and below with progressive deformity is that patient I showed you with the severe neck abnormality. Crankshaft or adding knot can still occur. And whether you use growth rods and produce a stiff spine or vectors and produce a stiff chest wall, you have to pick your poison because neither one of these are ideal. And kyphosis is always our enemy with any kind of growing device. So here's a patient that had an in-site diffusion that was sent to me with progressive kyphoscoliotic deformity that I put in traction to correct some of the deformity. Prior to application of a hybrid growth device with rib anchors below, screw anchors below. You see basically these pulled off, so we changed to screw anchors above and below, which nicely fixed the spine with now the rods broke, again with progressive kyphosis. So having a hard time controlling that. That leads to the last type of surgery for these patients, which are salvage reconstructions. We also consider preliminary traction in these patients as well. So this patient, I ultimately had to salvage with a 2-level BCR and posterior fusion at age 11. Obviously, we try and do this as late as possible to allow optimal pulmonary growth, but ultimately, when we can't control the spine, especially with progressive kyphosis, it's best to give up, stop growing devices, and produce and go on to a definitive fusion here with the BCR for correction. In addition, there's some patients that have just malignant transformation of their deformity that we have to do salvage procedures on. Here's a congenital kyphoscoliosis patient who's treated for over 8 years with growing rods and very vector constructs, sent to me here at age almost 11 with thin posterior fusion. It's bending, a single vector rod still in place. You see the bony deformity, severe angular deformity with neurologic impairment. 25 prior surgeries this patient had by age 10. You see all the scars. So obviously some of these patients, despite our best efforts, have malignant transformation. This patient underwent preliminary traction, slowly stretch out the spine, the spinal cord, provide optimal nutrition and respiratory therapy, then a complicated 2-level resection procedure, and ultimately C6 to L4 fusion for ultimate control of this severe deformity. Conclusion, US congenital sclerosis patients can be very difficult to manage, and they must be thoroughly assessed and individually treated. Hemivertebral precision short fusions work very well. Growth devices are the standard of care for some of these, but expected issues and problems, maybe not complications, can be anticipated. The ultimate desire is to optimize chest wall, lung, and spine growth while with minimal rigidity of the structures, either rib cage or spinal column. There's still much to be learned about the optimal care of these patients. I'm learning all the time. Thank you for your attention.